So welcome everybody. It's so great to see that so many people have joined from all over the place, and welcome to everybody here. So this is going to be a dialogue really, entitled, Is the Therapeutic Relationship Enough? We've got a little synopsis here. In 1957, Carl Rogers hypothesized that a set of relational conditions were necessary and sufficient for therapeutic personality change. But in the light of evidence emerging over the last 6 decades, what can we say now about the role of the relationship? Are relational conditions enough to bring about in-depth and enduring development and healing? Or is more needed? So we have Giancarlo Dimaggio and Mick Cooper, and just introduce them briefly. Mick, as many of you will know, is a relational therapist trained in person-centered and existential approaches, also working from a pluralistic standpoint. And Mick is co-editor of the Handbook of Person-Centered Psychotherapy and Counselling, co-author of Working at Relational Depth in Counselling and Psychotherapy. And Mick's research has focused on relational and dialogical approaches and issues, including shared decision-making in psychotherapy, the effectiveness of person-centered therapy for young people, and working with client preferences. And Giancarlo Dimaggio, welcome, is a psychiatrist and psychotherapist who lives in very hot Rome, where he works in the Centre for Metacognitive Interpersonal Therapy. Giancarlo has published more than 200 papers and book chapters in English. He's co-authored many books, including Metacognitive Interpersonal Therapy, Body, Imagery and Change, Metacognitive Interpersonal Therapy for Personality Disorders, and co-edited Integrated Treatment for Personality Disorders. He's editor-in-chief for the Journal of Clinical Psychology, in session senior associate editor for the Journal of Psychotherapy Integration, and associate editor for Psychology and Psychotherapy, Theory, Research and Practice. And lastly, just to add, metacognitive interpersonal therapy has received empirical support in Italy, Australia, Spain and Denmark, and is applied in Norway and also Portugal. So welcome both of you. And I think tonight Mick is going to go first. Go ahead, Mick.
Thanks, Emma. Thanks for that introduction, and welcome everyone. It's lovely to be here. I really wanted to do the dialogue just to give you a bit of background. Giancarlo emailed me and we were talking about the relationship. We've known each other probably about 20 years or so. We met at Dialogical Self, which was from Hubert Herman's, the idea of kind of multiple voices, and we kind of evolved in the therapy and the therapy research world over the years together. And we were talking about having a dialogue around this question around the therapy relationship. I think Giancarlo's in one of my posts around it, and some of the research that we've been doing. And I really wanted to talk to Giancarlo. I mean, he's a brilliant researcher and I'm sure a brilliant clinician. But also, I guess I've had this dialogue, and some of you might know that I kind of come from the person-centered field, and I've been talking to a lot of people in the person-centered field over the years, and quite a lot recently about the role of the therapy relationship. And it felt like it'd be really interesting to talk to someone from the kind of different side of it, if you like, who does believe, and as Giancarlo will say, about that often perhaps the relationship isn't enough. And I guess as someone from a person-centered stance, that's quite challenging, but it feels like an important dialogue to have. But I just wanted to share a little bit about where I've come from personally on this. And I have moved over the years, I guess, in a sense. So I trained as an existential therapist, and particularly under Ernesto Spinelli. And in our approach, there was a real emphasis on the relationship. It was a very, very relational approach to therapy. We were kind of fairly, what's the word, kind of deriding about techniques and about anything beyond relational strategies. They were seen as being mechanistic. It was seen as doing therapy rather than being in therapy and being real in therapy. And I guess my work has always been as a clinician, working in a fairly relational way. I'm not particularly structured. I work very much through empathic reflection and trying to be warm, and although that has kind of shifted a little bit, perhaps over the years. When I went on from that, I worked in the person-centered field, which again, obviously has a very strong relational emphasis, and Roger's idea of the core conditions being necessary and sufficient, so particularly empathy, congruence, and unconditional positive regard. And I guess that's very much the heart of a person-centered approach, that the relationship in itself is enough for therapeutic personality change, and that we don't need techniques, we don't need agendas, we don't need goals. That's not to say that we wouldn't use them if and when clients might bring them in, but essentially our role is to provide a caring relational crucible that can really facilitate that. And one of the books that I did with Dave Mearns in 2005 and recently updated on relational depth very much emphasised though that value and the power of the therapeutic relationship in itself. And one of the things we talk about there very specifically that I wrote was about the way that how do we deepen the relationship, or one way is to put techniques and methods and doing to one side so that we can be present, and we can allow the relationship and our being together to really unfurl. I mean, I was aware from 20 years ago when I started to look at the research that there was research maybe comparing CBT with person-centered approaches, showing that more technique-based approaches were more effective. But I think I was very, very critical of that research. I could see, and I often spoke about, the very powerful allegiance effect that was often done by CBT people with person-centered therapy that was delivered by CBT people and supervised by CBT people, manualized by CBT people. So I was very skeptical about any of that real evidence, and very much believed in the dodo bird that people like Bruce Wampold were developing, and Scott Miller and other people, that essentially therapies were about equally effective, and it wasn't the kind of therapy that made the difference or the techniques. It was much more to do with the relationship and even more so client factors. But I think I started to shift a bit, and one of the things that shifted me more towards appreciating the value that techniques that can have, and that maybe the relationship isn't always enough. I was working on a book called Facts Are Friendly, which was published in 2008, which was a review of the literature. And certainly that book does very much emphasize relational factors, it emphasizes client factors. But I think I could see when the research I did for that book was a really in-depth review of all the evidence in the field. And looking at specific areas, for instance, like phobias, and some anxiety disorders, it was really the evidence for particular behavioral techniques like exposure, like encouraging clients to face their anxiety. It was pretty strong evidence. And I think at some point I felt like, you know, if I was going to really be open to the evidence, and I wanted to be, and for me, it felt being person-centered, as Rogers says, the Facts Are Friendly is about being open to the evidence, that even though I didn't like it, and I kind of wanted to believe and show, in a sense, that relational factors were necessary and sufficient, but it was strong evidence, particularly around anxiety disorders, that other things could be helpful. And I think for me, that kind of then developed through thinking about pluralism. And some of you might know John McLeod, we developed what we call a pluralistic approach, which is really based around the assumption that different clients need different things at different points in time. I was talking to my son Zach about this, who's 13 now, so he can talk to me about psychotherapy, but being a bit of a master, he was saying, I said to him, Zach, do you know what the pluralistic principle is? And he goes, yeah, Dad, it's different people need different things at different points in time, in different universes, with different quantum realities, etc. He likes his science, so he was going on about quantum. I said, Zach, it's not quite about quantum physics, but it is about this idea that, you know, different people need different things at different points in time, and that therefore any kind of statement about anything being necessary and sufficient for all clients is probably too much of a generalization. And I think, although that's a very simple principle about different people need different things at different points in time, it does allow, I think, a much more nuanced consideration of the role of relational factors. So I guess where that takes me these days is thinking more that probably for a lot of clients, the relationship is enough, and that it can be very, very powerful, those relational conditions, not just the ones that Roger's highlighted, but probably other ones like the Alliance, goal consensus is another relational condition, management countertransference. If you look at John Norcross's book, he talks about a number of relational factors, and that those can be really powerful, incredibly powerful change agents. But also that probably for other clients at other points in time, there may be other things that they need, that they may really value psychoeducation, more structured techniques, things like EMDR, trauma-based techniques that may help clients go into areas that maybe the relationship alone can't deepen into, and that's okay. That pluralism doesn't try and argue that there is one thing that suits all of us, and I think that differentiation seems really important. So I would say the therapy relationship, I think, can be a really powerful change agent. I think some of the research on it by people like Sigal, Zucimano, showing the time sequence, showing the ways that it's not just that there's a correlation between the relationship and outcomes, but actually improvements in the relationship lead to improvements in outcome, I think provides some pretty compelling evidence that on average, it is a positive benefit. Just the last thing I want to say is about mechanisms, because I think, there's a lot of debate about whether or not the relationship makes a difference. But if we look at it in terms of individual factors, we also need to start asking, well, why does it make a difference, and what kind of difference does it make? What's the actual role? And I guess it's very nuanced, it's complex. I think that Rogers just really starts on it, really, and that's just one process pathway that he talks about. I think the relationship probably has a twofold effect. Part of it is about the way that it creates the context in which other things can be very helpful, and that's the position of people like Beck and the CBT people who'd say, absolutely, you need an empathic, congruent, accepting relationship, and then you need the techniques on top of that. And probably the relationship is very helpful in setting that, the crucible for other things to happen. But also then there are ways in which the relationship probably does bring about change in itself. We've seen in our work with young people, for instance, that by experiencing a very caring relationship, the young people can then feel more confident that other people are going to care about them, or other people are more trustworthy, and that can then be very healing. Also, that experience with on mute. If everyone could just check they're on mute, please. Yeah, and that also that being very cared for can allow things to be expressed that maybe wouldn't be expressed otherwise. So that as Dave Means would say, through relational depth, people can go to very deep places. So I think, just to conclude then, I think that the therapeutic relationship can be very powerful. Is it enough? I think it really varies by client. But Giancarlo, over to you.
Of course, Mick, I will not start from my slides, because listening to your talk, you evoke some reflections. So it is, where is my point in being here? In a way, that is why I came to realize that, to me, the relation in itself is not enough. Of course, I have a strong position. Is it necessary? Yes. I mean, it is not the relationship in itself that it is necessary, but it is the continuous process, the ongoing process of ruptures and repair in the therapy relationship. If you don't attend them, it's very hard that therapy can be successful at all. But is it enough? I'm pretty sure it is not. And I speak out of my personal experience, both as a clinician and as a supervisor. And why I came to such a, so to say, strong position. And my work is mostly, has always been on clients with personality disorders. And these people are full of a series of problems, which means many times their goals are not goals that we would endorse as therapists. And you can figure out the suspiciousness of paranoia. They want to feel safer against an hostile world. The request from the narcissistic client that perfection can be restored. Okay. And I was just supervising soon before this meeting, one colleague of mine, she's very nice, she's a friend, she's expert, and she was working with a young colleague, she's in her 30s, she's studying psychology or something like, I can't remember perfectly, and she realized that this woman complained a lot about her anxiety, but she couldn't give any reason for why she had panic attack, anxiety outbursts. And we realized that basically to her, being in therapy was not a place where she could heal her pain, but she would restore perfection because she did not accept any vulnerability. So basically, she wouldn't agree on anything because her very goal was to not have any emotional reaction. Okay. So with clients like that, it's very hard that you provide the necessary scaffolding, the warmth, accepting attitude, the Rogerian attitude, or if you want to see it from a different stance, you can work like a relational psychoanalyst, like, for example, Stephen Mitchell would have done, or Heinz Kohut for more, the innovation in psychoanalysis. But my experience is that they don't change. They still continue to endorse their pattern, to have their own goal, and to, in a way, to want to sustain them. They keep worrying, they keep enacting maladaptive behaviors, coping behaviors like aggression, avoidance, or repetitive thinking, worry, rumination. And, I've tried for the first few years to address them at the level of the therapeutic relationship. But then, I know, maybe sometimes I was able to fix the relationship, sometimes I wasn't warm enough, sometimes I was warm enough, or whatever the relational factor was at stake. And but the problem is that change was not sustained, or in many times, myself, my colleagues, we were frustrated because we were providing some kind of unconditioned acceptance, but things didn't change. And even if we were able to address problem in the therapy relationship and to adjust, to repair what was going wrong between the two of us, the therapist and the client, well, things in everyday life continue to remain still. So they didn't change. So I started to wonder if working at the personality-based level in the therapy relationship was enough. And more I realize that in order to promote both symptom change and personality change, we needed a model in which we did not only attend to the pattern in the therapy relationship, we did not only mind about attachment, and it was not just about offering a nurturing environment, something that could provide corrective emotion experience, to speak it the Franz Alexander way, but it is also about providing the necessary scaffolding for new learning. I mean, said otherwise, you imagine your young avoidant client, okay, severely avoidant. He's been shy since he was a child, and he just had a few friends, and he endorsed a view of himself as inferior, goofy, ridicule, and he figured out the others as critics, as harsh, humiliating him, and rejecting him. In have a date a romantic partner, a boy, a girl, whatever. He didn't have these experiences, and he learned to adapt to a very small and protective environment. Well, I really realized that even if at a certain point that boy came to realize that he felt safe in the relationship with me or with my colleagues who were treating similar clients, then he still adopted massive avoidance in everyday life. Okay, so what's the point? And at that point, I realized that without agreeing on some kind of exposure, imaginal exposure, behavioral exposure, role play exposure to negative feelings in the two-chair work, I couldn't achieve anything. Okay, and the more I work with personality disorders, the more I realize the need to agree that therapeutic change is about deciding together, so the contract, to commit both of us to do something. Okay, so that's why I came to include a lot of active ingredients in my work and in the work of my colleague. Then there is another point, which is the point of my slides. I will very briefly present them. That is, in a way, deciding to work only at the level of the therapy relationship and providing we actively the necessary therapeutic environment is something that allow we as therapists to feel safe, to feel in some kind of comfort zone and not taking risk. Because asking a client for an imaginary exposure about a moment of criticism, humiliation, abandonment, violence, trauma, of course makes arousal mount, and the therapist can be scared about that. But are we scared with good reasons? Is the client risking really something, or are we scared because we are scared? And because we are scared, we overprotect the client from a kind of exposure they could sustain. And well, I just have a very few slides I wanted to show. I hope I took the right.
That's fine. Giancarlo, you go on. It's really interesting. You take your time.
Pardon?
Sorry, just to say, Giancarlo, take your time. It's okay.
Oh, thank you. Actually, I won't take too much time. Sorry, I just wanted to see the proper one. Okay, hope this is the one. Just a moment. No, sorry, I just have to see the correct PowerPoint, just a few seconds. But basically, it's about a few slides about, just a moment, about studies that show, wow, this is it. Perfect, I'm ready. Okay, can you see this, my screen? Active ingredient, yeah? Okay, just a few recent studies saying that whatever we may think, we can deliver very active therapies, which are both safe and effective. I'm not saying that we don't mind about the therapy relationship. We spend 50% of the time in a session minding about the therapy relationship. For sure, it's kind of an obsessional attention to the therapy relationship. But listen to this data. First, randomized control trial, prolonged exposure, so classic behaviorally based therapy for PTSD. Exposures did not exacerbate symptoms. So is exposure risky? No. Similarly, imaginal exposure did not exacerbate therapy in a study of narrative exposure therapy for PTSD in refugees. Refugees means people who underwent a lot of life struggle. And again, exposure was safe. Then, let's play it hard. I want to have a disclosure of interest. I'm not interested in DBT at all. Zero. But that study is huge. It's modified dialectical behavior therapy for clients with complex post-traumatic stress disorder and history of sexual abuse. I mean, things like incest. So pure horror. And the trial was adapted DBT for these clients versus the old-fashioned cognitive processing therapy, which means, pardon me?
Sorry, Giancarlo, a couple of things. I think people are saying they can't see your slides.
You can't see us, man. Okay, sorry.
Yeah, I think it's on that. And I think the other thing is that I think you said you don't believe in DBT, not you don't believe in liberty. I thought you said you don't believe in liberty.
No, I do believe in liberty. I'm not a DBT therapist at all. I do believe in liberty, but I'm not a DBT therapist. Absolutely. No, absolutely.
I was worried. That's better.
No, I'm not a DBT therapist, but the study is powerful. Okay. Now, can you see the slides now?
I can see that, yeah.
Okay, good.
Right one now. Yeah.
Well, so it's DBT adapted versus cognitive processing therapy, which is the old-fashioned explore the alternatives. Can you see? I don't like it, but that's the story. It's 45 sessions, so 1 year. Exposure started at session 17, more or less. Well, the more exposure-based dropouts, I saw seminars, and they do very strong and powerful exposure. They ask the client to re-experience moment of sexual abuse. Well, they had less dropouts in the exposure-based arm and better symptom response. So was it safe? It was. Was it effective? It was. Similar, more or less same population, complex PTSD, and it was a randomized trial of imagery scripting, schema therapy based versus EMDR. 12 sessions. Of course, both EMDR and imagery scripting require for imaginal exposure. So you have to re-experience the trauma. You have to let arousal mount. And well, they had very few dropouts, very few, and very good outcomes in terms of PTSD symptoms, depression, and dissociation. So again, is asking clients to expose themselves in the session to traumatic scenes safe? Is it respectful? Well, data say it is. Finally, our own study, and it's a group-based approach in this, where we have both the individual, which is the most practiced way of doing metacognitive interpersonal therapy, and we use group. This trial is about the structured group approach, 16 sessions. It is structured. We give psych education about what are the motives that drive human behavior. So in a way, we take a very strong stance that is our client suffering comes from failure to fulfill some evolutionary selected goals, such as attachment, social rank, quest for status, exploration, autonomy, and the like. We ask for detailed narratives, and we ask the clients and everyone in the group have to role play at least one episode during the program. So it is very active. So, and it's group-based, so it's very strong. Well, we have just, the paper is about to be published in a few days. We have just delivered the proof. It has been accepted by Personality Disorders Theory, Research, and Treatment. And well, results were good. We had no dropout in our group, so they could accept the format. They felt respected and understood to a certain extent. Otherwise, they would have fly away from the group. And we had significant improvements on functioning, interpersonal problems, global symptoms, depression, anxiety, and alexithymia, so that the contact with their emotions increased. So, well, was a way to deliver something that was both humanly respectful and active. it looks like it was. So that's why I really wanted to enter into some kind of conversation with Mick. We knew each other for anything, at least 15 up to 20 years, more or less. Okay. And so that is my position, more or less.
Thank you, Giancarlo. I mean, it's very interesting. And I guess, you know, many of us in the UK are trained in relational models, person-centered approach. I think many people here are probably person-centered, integrative. So I think what you're saying is very, very challenging. I mean, of course, that doesn't make it wrong, but it's very interesting. And I think one of the things I just wanted to ask you to say a bit more about, Giancarlo, because it's a very interesting point, is are you saying that to some extent a focus on the therapy relationship serves the therapist rather than the client?
In what sense? Sorry, I'm not sure I understood your question.
It sounds like what you're saying is that to some extent a focus on the therapy relationship is in the interest of the therapist, that therapists are doing it to feel safe or for their own protection, yes, rather than because that's best for the client.
It may be. It may be, yes. Of course, it is not true for all therapists. Well, in a way, we can approach the issue from two, of course, I put things to the extreme, from two different maladaptive stances. One is the usual way that can endorse, for example, that by some CBT therapists. Many CBT therapists just assign the task. It's their responsibility to give the task. They assign to the client, and in a way they push the client to, to execute the task. And if the client doesn't comply, they become anxious and they insist more. Okay, I think that is detrimental to the therapy effectiveness. On the other hand, not delivering tasks, not exposing clients, can be honestly and sincerely done in the name of the client's best interest. But according to what I see in my colleagues, many of them do them for protecting themselves from fear of damaging the clients, sense of guilt, sheer fear, over responsibility, and shame. So we are not protecting our clients, we are protecting ourselves. So in a way, I may over-assign tasks because I have a personal need to be effective, to be powerful, to be in control, which is not good, by the way. But on the other hand, I may be too much respectful when it is not needed because I am trying to protect myself from my own personal feelings. So if I dare too much, I may hurt the client, which is the typical attitude of the South Italian mother. Okay, so my
story of the what, Giancarlo?
Of the perfect attitude of the typical South Italian mother. So overprotecting our kids. Okay. Please protect yourself because you may sweat too much and then you catch a cold.
But isn't there, but Giancarlo, I mean, there is evidence that when clients drop out of therapy, that can be, and that is because they can experience the therapist as cold and as too domineering. I mean, certainly if I think about my own experiences of therapy, that's not a good experience, that there needs to be some sensitivity, surely, with including patients who meet criteria for borderline personality.
Of course, Mick, I fully agree. And that was my, to a certain extent, initial position. That is, if you strive too much to make clients change and in a way to do something in order to feel better, they can easily perceive the therapist as domineering, controlling, non-empathic, and not respectful, cold. Well, just an example, I saw during a conference a simulated session delivered by 3 expert therapists. And one of them delivered a perfect session at the level of techniques, but it was clear there was not human connection with the client. He was reasoning with his manual. He was addressing this thing in his mind and not the real person he had in front of him. But on the other hand, I could see how difficult it is to convince my colleague to dare and ask for a guided imagery and scripting, ask for perform a 2-chair exercise, ask for assign a behavioral task, and much more. And I know that, well, Giancarlo, I'm afraid.
What do you, Giancarlo, sorry, I'm asking a lot of questions, but I'm just very interested, and I think for us it's a new perspective. What do you think then are the most important relational qualities for a therapist? What do you think relationally, how do you feel that therapists should be?
Well, that's a great question, Mick. And you know, consider that my background at the level of my heart is from relational psychoanalysis. I'm formally in the family of third wave cognitive therapists. But, you know, it's just a matter of some kind of political positioning. I'm there, I teach in the schools, but actually I've been raised as a constructivist psychotherapist, narrative oriented, you know, Bob Dimaggio and Hubert Hermans and the like. But I had a personal, as a client, as a patient, relational psychoanalysis. So I grew with Stephen Mitchell and Arnold Model, and then Jeremy Safran and Christopher Muran. I love the work. I had their book translated in Italy on my own copy signed by Jeremy Safran personally, and I'm very proud of that. And so that was my beginning point. So I mind a lot about being warm, respectful, curious, and focused. Maybe this is my weak point because I can be distracted. That you know, I know my children know, my colleagues know, my mind is always somewhere in the cyberspace or in the outer space. I try to be connected, and but these are important. But in the last few years, I'm more and more realizing that it's not just who you are to the client, but the way you are able to work in order to reach intersubjective connection. That is, which is another way to say we want a therapy contract continuously renegotiated. That is, are we really sure that your eyes and my eyes are focused on that goal, which is shared, and that we are both committed to do something in order to be there? And I'm pretty sure that neither my colleagues from the CBT tradition nor my colleagues from the psychoanalytic tradition mind enough about that dimension. Because either we, oh, sorry.
Giancarlo, that last dimension you're talking about, is this about task collaboration, goal consensus, or something different?
Yes, it is task elaboration and goal consensus, and realizing that this is explicit. Because if it is not explicit, and if the client doesn't say, well, I'm interested in the goal, and in order to reach it, I am committed to do something, things don't change.
Yeah.
And you know, my colleagues from any orientation at a certain point struggle to have clients do something, whatever the tradition they come from, but they forget that it is not their responsibility for clients to change. It's their responsibility to make sure you are aligned, that your eyes are on the same target and point in that direction and want to do something.
So how do you, Giancarlo, how do you understand all the evidence about the relationship between alliance and outcomes, and you know, John Norcross's books that have all looked at that? Do you, I mean, would you would that fit for you, this idea that the relationship is necessary but not sufficient? Is that how you would understand that? That it is important, but just as a basis?
Well, I think it aligns, because of course the therapeutic alliance explains only a tiny part of therapeutic change. So we have to learn a lot of things about what else is effective. There is a lot that remains to be explained. Of course, without a very good therapy relationship, or better saying in terms of Safran and Miran and Lisa Samstang and Catherine Eubanks, minding about actual ruptures in the therapy relationship and finding avenues to repair them, taking responsibility, not blaming the clients for things that don't work. It is of uttermost importance. If you are not able to deal with the dimension, you fail. Most of the times with personality disorders, you're pretty sure you fail. But you fail even if you only mind about that dimension.
Do you think, Giancarlo, I mean, you know, when I was talking about differences across clients. I know that your work is very much in clients who meet criteria for borderline. Do you think that there are variations across clients, or would you say that for all clients, whatever the issue, ultimately the relationship is not going to be enough?
Oh, that's hard. That's a difficult question. Of course, in a way, there are some easy clients, so to say, with small focused symptom disorder, in which you can take the alliance for granted to a certain extent. Okay, so as long as they are committed to some kind of exposure-based practice, be it for treating OCD or anxiety disorder, in a way, probably you can achieve good outcomes, even if you just monitor the therapy relationship. If it is good, you can deliver the technique. But when it comes to clients with many, you can call whatever you want, clients with narcissistic features, paranoid features, dependent features.
Share some. And just because I'm overall, I'm even drinking the bad.
Pardon. Sorry. And passive aggressive, paranoid, and well, they pose a lot of challenges to the clinician. And if you then don't mind neither about therapy relationship, then you get trapped into vicious cycle. But also, if you don't agree, and I just give you an example. I was supervising a young colleague of mine, treating a bright and successful woman who was in her 40s, and she had a serious dependence from her abusive husband and from her domineering mother. Okay, she complained a lot. She ruminated a lot about that. She had depression, she had anxiety, but then she didn't do anything in order to change. And it took a year. We worked a lot in supervision. We tried to fix the therapy relationship. We mind a lot about any potential rupture. But at a certain point, with due work, my colleague was able to have her clients say, well, I realize my life is painful and I live in a gilded cage and I'm not sure I'm ready to live. Okay. So you create the necessary scaffolding to make that woman be accepted, but then changing is a matter of choice. And only at that point, this client had the choice to remain in her environment or to try to break her pattern. And she actually did after another year. Okay, I don't know if I answered your question, Mick, but that's important to me.
Yeah,
that's a typical situation in which if you don't mind about the contract and if you don't focus that change is about explicitly deciding to do something out of the therapy room, the therapy relationship can be wonderful, can be a perpetual honeymoon, but your life in the other world is still the same.
Well, that's very interesting, Giancarlo. The relationship can be a honeymoon, but life outside can be the same. Emma, should we open this up to everyone now?
Yes.
It's been so interesting to hear your views, Giancarlo.
I'm sure there's a lot of questions.
Or comments. People can either raise their hand or and make a comment or a question or put it in the chat. Just to say, if you come onto video, it will be recorded. If that's okay. So if you don't want to be recorded, just put it in the chat. Karen, sorry, Emma, you do this.
So we've got an array of questions. Can you hear me okay? Yeah, okay. I suppose maybe we could start off. I know we've got a lot of questions going back in time. If we start off at the bottom here, and if anyone wants to post questions. So we've got something from Peter, actually Tiffany. Tiffany is talking about CBT and outcomes. Maybe we need to move to trust, the issue of trust. There's a broader question, Giancarlo, about the role of, in the therapeutic relationship, how much do you need to build a bond of trust, and how long do you think that takes? Because you talked about some time-limited forms of therapy, 16 weeks in your slides. I wonder, in terms of time and brief models or longer models?
Well, first consider that I work in private practice, and my colleague, my model has been mostly built from that framework. So time is what is needed. So I usually don't put time constraints. We try to be effective as fast as we can, but it can take years at times, especially when working with personality disorder. Well, trust in the process, is something it makes me a bit scary, because it makes me feel a bit passive. Okay, I want to be in the process. I want to monitor the process. I want to realize if I'm responsible for something that is not working. I want to make sure that the client is not enacting some maladaptive patterns. For example, it's very hard to be empathic towards the client when he is spiteful towards you, either explicitly or subtly.
Sorry, say again, Giancarlo, what did you say? Violent?
It's very hard that if the client is spiteful against you.
Fighting.
Yes, spiteful, is scornful. And then you cannot react with empathy. You have to say, well, sorry, but it's like you think that everything I say is bullshit. Okay, but if you think that everything I say is bullshit, it's a bit difficult to me, because I came with possible solution, but you don't like any of them. And basically, it's like you think that I'm not good as a therapist. I can accept it, but reacting with this combination of disgust and anger to my words, I don't know, it makes me feel a bit uneasy. And then you have to confront the client with this issue, not counter-reacting, but you have to put it in to bring them to the table. Okay, so in a way, so trust in the process, it is not something that goes smoothly and spontaneously. Otherwise, a client wouldn't be in our room. So it requires a lot of attention, both personal, technical, cognitive, and emotional.
Thank you. There was a question from, apparently Kanak had a hand up. I don't know if Kanak wanted to be unmuted and come in. Kanak?
Would that be okay? Am I audible?
Sure. Yeah, please.
All right. Yeah. So I'm a trainee, just finishing my training, and I work in India in a tertiary care setup. And we see clients from across the range of socioeconomic statuses, diagnoses, you name it. And the thing that I find very often is that there's a great disparity between clients based on what they expect of the therapeutic relationship. So while some are looking for a, what we consider a westernized model of talk therapy or CBT, others come expecting advice, and they say that you're the expert and you're the doctor figure and you give me advice. And we have this concept of what we call the guru-chela relationship, which is essentially, to translate it, would be a mentor-mentee relationship, wherein the mentee actually takes up residence with the mentor for a long period of time and undergoes spiritual guidance. Now, those are not as common today as they used to be, but I'm wondering, do you have any advice on how to balance this aspect of power dynamics when clients very clearly want you to be the one with the superior power in the therapeutic relationship?
Well, that's an important question. I would say if they want me to take control, I don't like it personally, but I can accept it as long as they realize that change depends on doing something out of the therapy room. Otherwise, it creates on one hand a power balance, but I am the expert in the first moment, but then I am the one to blame for change that is not happening in the second run. Okay, so I have power, but let's share it and realize that change is about doing something. Okay. For example, again, I have many clients that at a certain moment say, I don't know, you're the expert. Okay. And I told my supervisee, well, let's come with a predefined answer. And the answer is no. No, sorry, pardon. This is not how therapy works. Of course, I'm here. I studied a lot of books. I had a lot of training, and I can have some solutions, but the very solution is the one we agree upon. So let's think about it together, okay? Because it's very dangerous to accept that role of the mentor. That it bounces back.
I think that I would probably take a slightly different stance on this. I mean, one of the pieces of work that we've been doing is looking at different client preferences, and one of the preferences is around therapist directiveness, that some clients do want a more directive therapist and some clients want a more client-led, and that it's useful to have that discussion. Personally, I think it's useful to have that discussion up front, and we developed a measure that the CNIP that can be used to do that as a way of kind of gauging where clients are on that, and then trying to, I guess, have that conversation and trying to tailor the therapy to those different client needs. Certainly, I mean, this is a different level, Giancarlo, from your work around personality disorders, but where we work, for instance, in school counselling and kids in counselling, what we see is that some kids really want and really value advice and guidance. But there are others, and maybe you disagree with this, but there are other kids who say it was just so helpful to go in, to talk, to get things off my chest. It really was, nobody's ever listened to me before. I felt that when I could talk about stuff, it was like things I've never been able to say, and then I could go and talk to my parents about it. And I kind of think that if the counsellors had gone in with maybe a more challenging and a stance of, right, we need to do some exposure work here, I'm not sure it would have been right for all of the young people. I think listening to what the young people wanted in those populations, I wouldn't be quite. I think what you're saying, Giancarlo, for me, the value of that is enormously important. And I think it's very challenging, very interesting what you're saying about the risk of shying away from it. But I think I'd be wary about going the other way of saying, and that's what everybody needs.
Yeah, well, Mick, I think I pretty much agree with you. I would try and say it from a different angle, but I am very confident we are saying the same thing. And I do think that therapy need to be individualized. Okay, so it's not a matter of you are humanistic or psychoanalytic or third wave or CBT. It's the case formulation that wins. Is that specific person, and you have to accustom your therapy to that person. Okay. And well, there are clients then if you try and to adopt a directive stance, they just react. It's a power struggle. Okay, my very specialty is narcissistic personalities. And if I am the expert, either they idealize me, which is good to a certain extent, but then it's about fighting. It doesn't work. But when you have a person who's been deprived of experiences and learning and scaffolding, is not being followed by the community or by the family, then you provide advices, you provide suggestion, you provide some directiveness. Well, it's something like giving them what they needed. Okay. So then it's not a power, differential. It's about you're the pupil and I'm the trainer, and that's good because you are teaching some life skills they needed, and that is the position that fits with that person.
Yeah. Giancarlo, one thing I really want to ask you before we bring this bit to an end, and I know Philip's got his hand up, but what's your advice to maybe counsellors who have been mainly trained in a fairly non-directive way of working, who are maybe, have worked in a relational way? What would you say to them practically? Because obviously, people shouldn't be going and starting to do EMDR or DBT if they're not trained. What do you think is the next step for people who are trained mainly relationally to be doing from your standpoint?
Oh, that's a beautiful question. And well, first, if you have been trained as a primary training in a humanistic way, I think you have a great basis, because you have the primary quality that is being there with the client, accepting, non-judgmental, warm, present, positive. That's great. So that's basis. Then my suggestion would be just play, explore, experiment. Try to do something that is out of your comfort zone. Try and deliver a behavioral task. Try try with a guided imagery and scripting. Don't protect your client before your client asks for protection. Okay, I always say to my colleagues, well, you are afraid that you will hurt the client. Clients have very powerful defensive mechanisms. They are fast, they're automatic, they're spectacular. So if you put them out of their comfort zone, they will push you back. So just have their clients explicitly push you back. Don't stand back before they send you back. So take some risk and then mind about the therapy relationship. You can ask everything if you just think that your goal is not having that client do what you ask them to do, but you give them something and then you explore how they'd react. So when I asked you to do a guided imagery, how did you feel? You feel I was intrusive, domineering, disrespectful, okay? And you get feedback, and it's food for thought. And it's something that can be very interesting. And with that attitude in mind, you can dare to do everything. I always say to my colleagues, I want my clients to fuck me off in order to not do their something. Because when they say, doctor, fuck you, okay, I'm done. That's good. I've no problem with that. Okay, of course, I do it very jokingly. It's in general, the atmosphere of my personal session is very playful. Okay, and I try to stand. Probably you can get it in a playful mode as long as I can. Use irony and joke and be serious when we can. But I dare, and I soon monitor. Okay, what is your reaction to my offer, to my proposal? And with that attitude, you can then use EMDR, you can use DBT skills, you can use guided imagery and exposure and rescripting. We use a lot of body-oriented work, which is spectacular, because we always monitor what is happening in the client. So it's a matter of becoming curious.
I mean, from an ethical standpoint, you do need training in these approaches. Yeah.
Pardon, from an ethical standpoint.
From an ethical standpoint, say with EMDR, you need some level of training.
Of course, no, of course. So sorry, no.
To emphasize that.
With any of these techniques, you need to have some training, and to have a very solid background, you need to have supervision. But if you have learned these things and you want to explore, you can have a humanistic background and then play with something you learned. And then you discover that you can be the same therapist with more instruments. And it's just more fun. I think Philip raised his hands 1 hour ago.
Emma, just to say, we normally have a break at 7. And maybe what we'll do is we'll take Philip, and then if people, because it's for an hour, so we have a break, or like literally people want to go at 7, and then we'll have just a more informal discussion afterwards if people want to stay on. But let's take Philip, and then we can maybe finish after that. Philip, can you come off mute? I'll just...
Yeah, thank you very much for giving me this space. I hope my nerves hold up. I work in a university environment. My work is very brief, mostly by circumstance, so not by design. And at the same time, we work a lot with people with suicidal ideation, risk, and all of that. And I find I'm very inspired by your work, Mick. Existential therapy, pluralism. I'm also very interested in Ernesto Spinelli and what he has to say about the relationship, and that's very close to my heart. At the same time, I have had some training in sort of like that is more like focused around some CBT backgrounds and so on. So I hypnotherapy, therapy, those sort of things. What I find and where I really relate to you, Giancarlo, is that actually I've come more and more, the longer I work, that I'm getting more and more interested in what I call congruence. You know, like what is congruence to me? And I think in a pluralistic sense, it is about sort of like, and in an intersubjective sense, it is about connecting. It's all about connecting to my client. To be effective, it has to connect. What happens, that's how I experience it. What happens in the therapy room, if it doesn't, I agree with you, if it doesn't translate beyond the therapy room, you know, what's really going on? You know, what kind of bubble are we creating that doesn't allow the learning or the work to sort of like go beyond the space? And I think that I agree with you on that. It's like, that's when I feel like I get creative and I think about how I connect with people. And yeah, so yeah, I just wanted to share that. And that's how I understood your contribution, Giancarlo. I read it more like this. Yeah, you know, I'd have the courage actually to ask myself, you know, am I just sitting here ticking boxes, you know, being congruent, being empathic and non-judgmental, but what actually is happening in the relationship? How am I actually connecting, and how is what is connecting in the therapeutic space actually translating beyond it?
Yeah, thank you, Philip.
Well, Philip, I think that you are very courageous because working in a unit with suicidal clients, you know, I think require great personal qualities first, in order to attune to these people and enter their pain and create a connection, respect them, accept them. But then, you know, there is the need to create the connection and find that part of the person who is there because he or she doesn't want to commit suicide. Okay, so that's the part of the contract, that's the part of the connection, and that's the part of how we can export the connection we established here today in this room home when you will be caught by suicidal impulses. Okay, so that's the part in which we need something explicit and where we need active work. I don't know if I you know, if I said something meaningful, but you know, it's combining the capacity to stay there with connecting to the part of the client who is in charge of deciding what to do about the therapy.
Thanks, Giancarlo. Emma, should we bring this bit to a close? And then if people want to stay on like another 20 minutes or so, they're very welcome to.
Yeah, sure. I mean, if anyone wants to stay for a more informal sharing chat kind of time, please do. But those of you who may need to go, it was scheduled for an hour, so we've already run over a bit. So please feel free, and it's been such a pleasure to see you all. So thank you so much. Anyone that does need to go. I'm sure I speak for Giancarlo and Mick in saying, you know, it's been a great discussion.
Yeah, thank you for joining us. And just to say, next month we have a debate on neuropsychology and role in counselling psychology. So there'll be information about that. But we'll hang on, but just let's say goodbye to those of you who need to go. Giancarlo has to get away for the football in 20 minutes anyway. So.
Yes, exactly. That's a very important task. It's Italy, Switzerland.
What time is that kickoff? 8:30? Is that right? At your time?
Yeah, 8:30 my time. Yes.
Yeah.
Giancarlo, I wanted to tell you about some research that we did.
Yeah, good.
And we looked at therapy. It's based around the work of Judith Jordan and the idea that we all have ways of disconnecting from people, strategies of disconnection. So we asked therapists about their ways of disconnecting, and they talked about things like some were about being quite compliant and being kind of very friendly. Some were about behavioral ways of disconnecting. Some were more to do with emotional disconnection. And then we asked them, which of these strategies most leak into your therapeutic work? So what are the ways that you disconnect in everyday life that are most likely to turn up in therapy? And the ones that the therapist talked about was very much what you say. It was about being compliant, not challenging, being very kind of listening, actually, that they could recognize that sometimes listening to someone was actually a way of disconnecting rather than being connected. So I thought that very much supports, I think, the point you were making, that sometimes disconnection, sometimes being nice can be a way of disconnecting. I know that's a lesson for me.
Well, Mick, I agree 100%. I often talk to my colleagues, to my supervisee, and say, well, if the relationship looks like it is smooth, but you have a sense that the client is hostile or withdrawn, and you don't attend it for fear of hurting the client, or fear of being criticized, you're not healing anything. Okay, you just separate from each other. Okay, if you don't attend explicitly to what is going on and is problematic, you remain dissociated from each other. Instead, when you say to the client, it looks like you're not there with me. It looks like you are not very interested in the things you say, and maybe with good reasons. Okay, but I feel it. Shall we talk about it? Okay, then you're not breaking anything. You are congruent, and you are recreating true intersubjectivity. That is, what there is really between me and you in this moment is distance. So let's talk about distance. And if we realize that there is distance and we talk about distance, then there is connection. Okay, so I'm not nice. I'm saying that I'm distant, you are distant, but let's talk about it, because it's who we are in this moment to each other. So I think it's pretty much consistent with what you said.
How much do you think, though, Giancarlo, this style of therapy that you're talking about is you? Because, you know, I can see that, you know, I've always experienced you as someone who's quite playful, who's quite jokey, who's quite maybe confident. You know, if I was, I mean, I'm someone who's quieter. I'm sure there's other people who are even quieter than that. Can they be that challenging, more kind of a kind of let's do this, let's do that person? Do you think they should try, or is it more about recognizing who they are?
Well, that's a, I have my own personality. Okay, so some things are easier to me because of my attitude, but my personality, for what it is, maybe not the right one to some clients. Okay, so maybe they need a more caring and protective and nurturing attitude, which I have. I am a nice father. I love my children, by the way, and I love my clients also when we create a connection. But I know what I would say is that each of us as therapists, we need to stretch our own personal boundaries. Okay, so if I am a bit too fearful, I need to overcome part of this fear. If I am too boastful, too overconfident, I need to tone down that and more learn to play like equal. It's more about, you know, becoming something a bit different from you, who you were. So we have to unlock ourselves to a certain extent. And then each of us is a different entry point in the therapy room. Okay. And I don't think there's a better one. Okay. We have our, each of us has qualities and problems. I know my weak spot. For example, I cannot work. I couldn't work in Philip units because it's too much of the burden of responsibility would be too much for me. I wouldn't sleep simply. I couldn't work with clients with serious paranoia and aggression for the same reason. Okay. I'm very confident in dealing with narcissistic, with obsessive compulsive disorder, personality disorder. I have no much problems with passive aggressive personalities. I think I'm good with mild paranoia, but it's me. Okay. Other clients are much better with borderline personality disorder, for example. It really depends.
Thanks, Giancarlo.
We had a question earlier that was really interesting as well from someone in the chat. And it was asking about the point you mentioned, Giancarlo, about you create something with your client and you feel some change in the relationship with your client, but it's not mirrored in the outside world. So I wonder, in terms of working, is that about the muscularity that you bring in
about, pardon, Emma, about?
Is that about working more congruently, using yourself as the clinician and taking that risk and going up against that fear to try and, you know, push those limits, in a way disrupt, you know, maybe to use a psychoanalytic term, the transference.
Yeah.
That you're disrupting something in order to make that change, that dynamic change.
Well, now that's a powerful point. Now I'm just thinking. I tell you, for example, I had to. For example, I talk about a couple of personal experiences. I had to learn to be completely confident with the sense of powerlessness in the session. Because in my early years, I was overactive for a series of reasons. Okay, I had to prove to myself and the world that I was good, that I was bright, that I was as smart as, and of course, so I entered into a lot of power struggle with my clients. I tried to convince them that my reading of their schemas was correct, and it wasn't, you know. But I was too stupid to realize that I was just, you know, having to show up myself. And the more and more I realize how difficult, how powerful is to realize, okay, in this moment, the only thing I can say is, if you don't give me a warrant to enter into your soul and do something, I can do something, okay? And be happy with this feeling of radical powerlessness. So embrace it. It's something that, you know, if you told me about that 15 years ago, I would have laughed at that stupidly. Now I realize how powerful it is. Just as an example, I'm not sure I really answered your question, but you know.
I think you did, and it links to something you said earlier, which made me think of something Gabor Mate says, which is don't get
Okay, baby, I'll get you some food now.
Don't get attached to the outcome of your client, because it puts too much pressure on the client.
Exactly, because you know, sometimes we need a client to improve. Because if they don't, again, it's a matter of, it's our responsibility. We feel guilt, we feel ashamed. We think that everyone will know we are failing, so we will fail into misery at any level, okay? So we are not confident at any level when clients doesn't change, when clients don't change, okay? And then it's a matter of regulating yourself and realize where is your limit And if the client is committed to change, and sometimes, you know, it needs some much self-control to pass from I have to change the client to let's think about it together. On the other hand, from the other angle, just thinking, okay, I'm with the client, the relationship is good, things don't change, but this is what I should do, so I'm okay. No, then you have to realize that you need to do something, because you know, client doesn't the client doesn't self-heal. Okay, so both perspectives may be a problem.
Thank you. Does anybody else have a question or want to raise their hand if they want to come in and ask Mick or Giancarlo a question?
Can I tell you an anecdote? No. Sure. Well, I was delivering a training. During training, I do live sessions with the participants, and not role play, true sessions. Okay, sometimes they're very powerful, and I ask them the emotional reactions to all of the audience, so counter-transference, so to say. And one colleague told that while watching to the session, she dissociated. And arousal mounted. I said, well, what's the story? What happened? And she told me, oh, I don't know. I know I experienced some kind of fear. Okay. So I asked her, will you come here and sit in front of me? So let's talk briefly about that. And she came to a horrible story where her mother forced her to color her hair into blonde in order to let her more in touch with her northern origins. So sheer violence, okay? And so she started to elaborate the story with this crazy, violent, domineering mother. And then she told an episode about she was 11 and her mother threatened to kill her with her iron, the iron to iron and she was about to throw at her, and it was an iron made of iron, not the modern one in plastic. Okay, so she could really kill her, and she was extremely scared. And you know, it was more or less the end of the training. I told, well, okay, let's try. Would you like to figure out your mother's face here? Okay, so kind of an informal imagery. But then I realized I could do more. So do you feel like role-playing this interaction? So I'm your mother. She accepted. How did I feel in that moment? Scared. I was scared. I told her, let's take the water bottle aside. So we don't want objects between us, because I could feel some danger. And then I say, okay, I'm your mother. I will yell at you. I will threaten you. And you answer me. So I started to, she accepted, by the way. She was very afraid. And then I said, okay, then answer me. And then again, answer me, but louder. She did. Okay, I will shout louder than you now. Are you prepared? Yes. So I insulted her. I threatened her even stronger. And she really was strongly emotional. And I said, no, you have to yell at me, I told her. You have to say, mother, you cannot treat me this way. Then she elaborated in her own words. And at a certain moment, she yelled at me and said, well, no, you should not treat me this way. And I asked her, how do you feel now? And she told me something that I could never forget. That is, for the whole experience, I felt fear here. Then I felt the sensation climbing. It arrived here, and then it became anger, and I realized that it could no longer come down and become fear again. Okay, I'm pretty sure that I couldn't reach this small momentary change, but so powerful, if I didn't dare to become her mother. Okay, I took some risk. Yes, I knew I could, but it was risky. But I'm pretty sure I say to my colleagues, you don't get the same moments just working through the therapy relationship. You have to create some kind of pretend play space where things can happen in a different mode. And then you let arousal mount, and you can get something that is not usually happening in the therapy relationship. You know, let me, you know, I'm a solid rock scientist, but it's kind of a, you know, it's, you know, I think that exorcism has something to teach us. Of course, just it's a metaphor, no more than that. Okay, it means create something when you let ritually arousal mount and then control it, and then you get something more than in the usual talk. I don't know, probably catharsis, yes. Mm-hmm. But of course, I don't advise you to do it in your everyday life. So, you know, I have 30 years of experience, 2 long-term personal psychotherapies, 4 training in different modalities. So, you know, consider that, you know, that's the background. So you don't do it after 3 years of experience. Okay, that's important.
Thank you. That's a very, very powerful story, actually. It's really stuck with me. Definitely. Thank you for sharing.
We have many of them, not as powerful as this one, but you know, sometimes we really try to let the temperature mount.
Yeah. You're talking about bravery, really, in many ways tonight, I think, aren't you? Yeah. Does anybody else want to come in with a question? I know we haven't got very much time left, but does anyone want to raise their hand or type a question in the chat?
Just to Sally Jeffrey, yeah, of course, the inspiration from Gestalt is huge. I think modern psychotherapy owes much to 3 personalities at least: Moreno, Fritz Perls, and Pierre Janet. Philip.
Giancarlo, since nobody else is going, I may as well go again. I just wanted to ask very quickly. I think you brushed on that, sort of like the relationship with self-doubt, and this is you know like questioning yourself, because I think this is kind of like the thing that interests me very much, and I think that's where I heard Mick as well come in with, like, you know, well, how do I know I work safely? You know, how do I actually know where the boundaries are? Because I hear what you're saying. You know, if I sort of like take risks, you know, this can really produce results, but the nature of risk is that they're risky and, you know, they can go in different direction. So how do you monitor that? And how do you kind of like work with your self-doubt in that situation?
You know, in my model with my colleagues, we really monitor in every moment our patients' reactions, and we attend to them in the moment. We really don't mind about being effective. We mind about trying to do something and then explore the reaction. Our goal is having something to explore together with the client. If you have this curious attitude, you can dare much more, because whatever happens, it's under control.
So it's feedback. You're saying the key is feedback and using that to.
Exactly.
I've got one last question for you, both of you, Mick and Giancarlo, really. I wonder if you feel like sometimes therapists can use a model as a shield.
Can use, pardon?
Can use a model as a shield.
Very often. I think I always say to my colleagues that I don't want you to deliver metacognitive interpersonal therapy. I want you to understand that person, and I don't even want you to understand that person. The real knowledge that is interesting is the one that is shared within client and therapist. If it is in my mind and is consistent with the model, I don't care. It's what we know together and what we can use together. That's what really matters. So the model, you know.
Yeah, absolutely. And I think it can be a shield. And I think what Giancarlo, as you were saying, Emma, has been talking about tonight is about courage, and about the courage to sometimes put that shield down a bit so that we can really be open to the client in front of us and relate and encounter and work with that person rather than the specific model that we're committed to. So it's been, Giancarlo, it's been fantastic listening to you. I've learned so much just listening to you and hearing your views on things and been challenged, and it's been really, really, it's been great. And thanks everyone for coming along and listening to the dialogue and being part of the dialogue. Emma, back to you.
I don't know what to say. It has just been a fantastic experience. The question, your comments, your observations, yeah, that's spectacular.
Good luck with the football.
Yeah, thank you. Cross fingers.
Thank you very much, and thank you everyone for joining in.
Thank you very much.
And you know, we cheer on Italy and Switzerland tonight.
Yeah.
We have no commitments to a model.
Yeah, exactly.
Yeah, no model affiliation.
Bye bye everyone. Look out for the talk next month.
Bye bye.
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 Thanks, Giancarlo. Thanks,
Thank
Emma.
Mick. Thank Emma. Thank you.